I'd now request Dr. Arup Chakrabarti to speak on IFIS. Once we're done with these general topics, we'll go on to specific devices. So Dr. Arup needs no introduction again. He's been teaching for a very long time. So let's hear him on IFIS.
So, very good afternoon, friends, and thank you, Suven, for calling me for yet another of your very popular courses on small people, which you have been giving all over the country and international fora. So, I have modified my topic a little bit, and I'll call it IFIS Revisited. So, the video that you see is actually the last in the series of very graphic, intraoperative people, small people surgery. And this was done about 15 or 20 years back, and subsequently it came to be known as IFIS. That time we didn't know. Since then, when the first 2005, when David Chang and Campbell described IFIS, and subsequently there's been a lot of inputs in the literature to major meta-analysis have come up, and I have learned from experience. I have developed an SOP for myself, and I have not encountered any such case in my surgical practice, and I'm going to just share with you the SOP which I have been following, and that's a dynamic SOP. It keeps changing depending upon newer information in the literature and my own personal experience. So basically, a little bit about what happened in this, what was described in this 2005 article. So it was noticed that all these BPH patients who were put on uroselective alpha-1 blockers, that the alpha-1A particularly, that was tamsulosin. So they demonstrated IFIS, the features which was known as intraoperative floppy iris syndrome. These are the same receptors which are present in the eye, in the dilator muscles, and those muscles also got blocked by tamsulosin, and this is what is happening. And subsequently, it was noticed that there are many other medications, many other systemic medications were also responsible for a similar situation. So today, when I come across a small pupil situation, I classify them into two categories. One is the non-IFIS type, that is the traditional type, and the IFIS type of small people on patients who are potential IFIS candidates. BPH patients need not be BPH, but there are a host list of other medications that also have to be taken into account. It is also important to know that IFIS candidates may not have small people to start with. They can have a relatively large people to start with. So other medications that have been implicated are, for example, silodosin, which is again a uroselective alpha blocker. So that is even worse than tamsulosin. So today, if I have to start a patient, if a neurologist asks me that which alpha blocker should I start my patient on, I would say it is alfuzosin. This is not uroselective. This is non-specific type, but it, unlike the other, non-selective alpha blockers, this does not give us the postural hypotension, which was the major problem with the other medications because of the slow GI absorption profile. Then antipsychotic medications like benzodiazepine, skutipine, and also implicated. So we definitely look into a drug history. So this is what we have a matrix which is put up in my preoperative counseling room. And in spite of all the best efforts, there are some patients who still get through this mesh, through this mesh work. And we finally find out that they have forgotten the history of tamsulosin intake. So these are the two major meta-analyses which I have used to develop my SOP. One came in 2011 and 2022. 2022 meta-analysis basically confirmed whatever we had known about IFIS earlier, and then it came up with some newer concepts. What we had known earlier, that it is more common in the male sex. Of course, the female patients also can develop IFIS. Hypertensive patients, whether it is hypertension per se or the antihypertensive therapy that was responsible. And another concept that came up was decreased dilated pupil diameter. I find it extremely important, and that is my sole criteria today as to how we go ahead in an IFIS candidate. And again, in the antipsychotic medications, etc., etc. So another interesting summary from this particular meta-analysis was some of the conventional prophylactic measures that people have been taking. So, for example, discontinuation of tamsulosin. I don't do it personally, but there are some people who have been doing it. Use of preoperative topical atropine, using intracameral epinephrine or pre-op topical NSAIDs. Statistically, they have no significance. So though we do it, but still, statistically, it is not proven to be very useful. Pre-op dilated pupil diameter. Say, for example, studies have shown that if your pupil doesn't dilate beyond 8 millimeters or 6 or 7 millimeters or 6.5 millimeters, they become IFIS candidates. So it is very cumbersome. And you keep the patient waiting in the OP and dilate and measure it. And measurement protocol also is quite cumbersome. So I use the intuitive pupil pupil to limbal diameter. And this basically on the surgical table, I measure, I just get an estimate of what is the pupillary diameter, what is the limbal diameter, get the ratio. If the ratio appears to me less than 60%, I treat this patient as an IFIS candidate. So in that case, I would be using T plus ultra or Phenocane plus, no financial interest. Both these medications do extremely well for all these potential IFIS candidates. And if I have a very small pupil to start with, like what you see here with comorbidities, and fellow A had not done well in terms of IFIS manifestations and management, so I definitely be using a pupillary device. And my go-to pupillary device in this case, of course, would be a iris hook, because iris hooks also takes care of the peripheral iris prolapse, unlike a ring device which just enlarges view centrally, but the iris still is floppy on the peripheral side. So I won't show the video, but this was a case which I had who developed IFIS in spite of all these precautions, and the patient did extremely well post-operatively. In a week's time, he had a vision of 6.6. This is a video that I would like to show you. So here, it was again an IFIS candidate. So Saurabh had shown a similar case, So temporarily, there is a tendency for iris prolapse. So here, instead of depositing the iris from the main incision, I go through the side port, and then I create a paracentesis incision a little behind the original incision, as you see here. And then I push in my iris hook. So that iris hook, it retracts the pupillary margin, and it takes the iris away from harm's way, so that subsequently phaco handpiece can be easily inserted, and intraocular lens can be easily inserted, and surgery goes off uneventfully. So the subincisional iris hook definitely is a very good concept in managing iris prolapse from the main incision. So basically, for mild to moderate IFIS, I would follow these precautions and make a very good incision. For that matter, you should make very good incision in all your cases. The lower IA flow parameters, appropriate OVD strategy, and severe cases, of course, you go for a ring pupillary dilating device or an iris hook. So friends, cataract surgeons should be aware of the identified factors predisposing to IFIS, which we have come by studying the various meta-analysis. Properly assess and evaluate these to stratify the surgical risk in a given patient. Use all the necessary pre-op and intraoperative measures in high-risk patients to achieve an adequately dilated pupil intraoperatively. And failing to do so could turn a routine surgery into one of significant visual morbidity. Thank you so much for your kind attention.
Thank you, Dr. Arup. And thank you for finishing before time.